over to you. Thank you very much. Um, it's a pleasure to invite all of you. This is a topic which is extremely important for surgical oncology D&D students. In fact, every exam you happen to face an examiner in the practical exams, you would have at least 2 to 4 questions based on the TNM classification, and most of the OSCE systems that are set up would have at least 1 to 2 questions from this particular topic. And the essence and the pyramid and the base of any cancer treatment is a proper staging. And it is unfortunate most of the students don't read the HSCC TNM manual which is there. They just open their iPhone or they open their smartphone, they just see the staging and they close. But the history behind it, the general principle and the concept why this particular staging is formed, nobody actually reads. So this is a very important topic, and this is the main basis and the foundation for the entire oncology treatment. So first we will see that why do we need to stage a cancer. Remember, the treatment of cancer is different for each site, type and each stage. The same cancer in 2 different patients is not same. The same cancer in each site is not same. And the same histological variety of cancer with same prognostic marker is not same. So the stage is very important for every cancer. Diagnosis is incomplete without a complete and proper staging. In fact, as a student, once you examine a patient, work them up with various procedures, investigations, scans and biopsy, before you plan and contemplate a treatment, the first thing you have to do is confirm the diagnosis, stage the disease, then institute appropriate treatment for that particular stage. So staging, you must write HSCC TNM staging on the patient's file along with the histological diagnosis. Staging is the first and foremost part in the cancer treatment after you confirm histological. Remember, the term cancer, ICD, WHO staging, what you put is only after you histologically confirm. You can't start a treatment in oncology without a histological proof except 1 or 2 conditions. One is a pancreatic cancer, otherwise which actually straight away on an imaging workup is a malignant lesion. Second is a solid lesion in kidney more than 2 centimeter on an imaging looks straight away as a renal cell carcinoma, or liver lesion where alpha fetoprotein is 15 times normal than the normal limit. Testicular tumor with raised germ cell tumors with tumor marker. Except these 4 conditions in the history of solid tumors of oncology, no other places you can ever start a treatment without histological confirmation. So whenever any cases is there, you say first I'll confirm my diagnosis, I'll stage the disease, then I'll institute appropriate management for that stage. So staging according to anatomical extent of the disease is based on the established experience that survival rates are higher for cases in which the disease is localized to that organ. When it spreads to lymphatic and lymph node, then it is more. Remember, always stage 2 is better than stage 1, stage 3 is worse than stage 2, stage 4 is worse than stage 3. All the solid tumor, except there is one exception for this particular tumor. And that particular exception is stage 2 of hepatoblastoma is better than stage 1. Stage 2 is better than 1 in hepatoblastoma. Please go and read why stage 2 is different than stage 1. Post neoadjuvant treatment, re-evaluation is stage 2. Upfront without any treatment is stage 1. And the other one is stage 5 of Wilms tumor. That is the only thing where stage 5 could be better than stage 2, stage 3, stage 4 of Wilms tumor, stage 2 hepatoblastoma. These are the only 2 TNM HSCC staging where higher stage can have a better prognosis. In all other higher stage is bad. So please go back and read why only hepatoblastoma, Wilms tumor has stage 5 when everywhere it is stage 4. Testicular tumor has only stage 3, no stage 4. Even if there is a lung liver met, stage 3 only. Well differentiated thyroid cancer in a less than 40 year has no stage 3. So these are the exceptions you must know. I'll repeat again. Hepatoblastoma and Wilms tumor, higher stage has a better prognosis. Stage 2 better than stage 1 in hepatoblastoma. Stage 5 is, in Wilms is better than stage 2, 3 or 4. Wilms is the only one where there is stage 4. And then testicular tumor has highest stage as a stage 3, not beyond that. And well differentiated thyroid cancer in a young patient has only stage 2. So you must know these differences. So what is TNM? Tumor node metastasis system. Remember, this was introduced between 1943 to 1952 by Perineural. He is from Institut Gustave Roussy. In the France, there are two major cancer centers. Outskirts of the France, that is a Paris, is called as Village Juif. Outskirts of France is a village. That is where one of the top regional cancer center called as Institut Gustave Roussy is there. Very close to that, there is another institution near the village. That is a Paul Bros Hospital. If you want to learn the liver surgery, liver resections, that is the place in the world to go, which is a place of bismuth, where we all read bismuth classification. From Paul Bros Hospital in Village Juif, Paris, very close to that, about roughly 4 miles, you have Institut Gustave Roussy, that is a Perineural. So this question, if you encounter me as a practical examiner, every student will have this question asked in their practical. So learn this. And you can see this is the first TNM book which came in 1979. Can you see that this is in France? And this is autographed and signed by himself, Perineural. So this is the person, Perineural, 1912-1990 from Institut Gustave Roussy. He is regarded as the father of the TNM. So history of cancer staging, he brought this to have a common language. Suppose imagine me sitting in Bangalore, I say, okay, I saw a stage 2 breast, stage 2B. A person sitting in Delhi would exactly know what it means. Suppose somebody is sitting in Bhubaneswar and say, oh, I have seen a lady with a big tumor and I feel one node and I can't make out, what is. They would suddenly say, oh, this is stage 3A, I understand what it is. They say stage 3B, oh, then I understood, oh, this patient has intramemory and axillary node. Or we say, okay, this is higher stage, supraclavicular node. So the purpose of staging is to have a common language. Now, subsequent to this, the clinical classification of cancer by the League of National Health Organization in 1922 adopted it, and International Union Against Cancer and TNM Committee adopted it. So the AJCC first meeting were organized on Jan 9, 1959, and then this was adopted by Remember, TNM existed before AJCC, the American Joint Committee of Cancer, adopted the TNM and they got merged at that level later. So what is the definition? The definition is the staging of cancer is a classification of the disease in terms of extent, progression, severity. Why extent? T1, T2, T3, T4, bigger size. Progression, node positive, node negative. M1, systemic metastasis, non-metastasis. M1A, non-regional lymph nodes. Like, you have a lower CA esophagus, there is a supraclavicular node, M1A, stage 4. You have a cervical squamous cell carcinoma esophagus, there is a celiac node in that patient, it is M1A, non-regional node, stage 4. So it shows progression. Severity. TNM staging also has PN+, perineural invasion, L1, V1, lymphovascular space invasion, G1, G2, G3, grade 2. So severity is also told. So extent, progression, severity. So that way the prognosis and the choice of treatment totally changes. You will know whenever you see a cancer patient, you have to put it on the paper, AJCC, TNM, up to last, TNM, VL, PN+, everything. Then you write intention of treatment, palliation or curative. Then you will really know what we are looking at and how and what we need to do for this. Now, initially, when the TNM committees sat to identify various staging, these are all the stagings available at that moment. The American Joint Committee on the Cancer, the British BIGAC classification, Canadian Committee on Cancer Staging, then we had DSK, the French group, the ICC, the JJC Japanese. So you can see that now common language never existed and all this problem. And then in 1958, FIGO, International Federation of Gynecology and Obstetrics, has engaged and they switched over from AJCC to 1958. This is one of the few. There are few conditions where TNM staging is extrapolated. That is in liquid malignancy, like you have Ann Arbor staging. Even soft tissue sarcoma is the only one which has got GTNM staging, but an extension of TNM. Or you have a gynecological oncologist. But now, ever since last 10 years, TNM, AJCC and FIGO are same. So if you say stage 1 endometrium in TNM, that also is stage 1, A or B, same in FIGO. So now FIGO and TNM is synced, so pretty much they are same. So like there are other staging systems which are there. For lymphoid, you have WHO and Ann Arbor staging. Lymphoid malignancies, lymphomas, non-Hodgkin's. For multiple myeloma, you have Dury-Salmon staging. For pediatric lymphoma, you have St. Jude staging. For brain tumor, you have WHO. Extremely important, these are asked in practical exam, what is the staging system? Also, this is a 10 marks question, what are the various staging system available in oncology? So, you must know that. Now, what is the purpose of staging? This is one of our important question you get in, DNB theory paper. What are the various staging available? What are the purpose of staging available? And what are the new modifications you had in new staging compared to previous? This was the question which we had previous year. So the purpose and objectives of these are to aid the clinician in planning treatment selection adjuvant, to give some indications of prognosis. See, for example, stage 1A lung cancer non-small, no adjuvant chemo radiation required. The moment it is stage 1B, patient needs adjuvant chemo. So you must know the difference between 1A and 1B. See how the planning changed totally. Same, suppose there is a tumor thrombus in vena cava, below diaphragm, above diaphragm. Suddenly the staging of that renal cell carcinoma becomes stage 3. If there is a Gerota's fascia breached in RCC, T4 becomes an indication after curative, cytoreductive nephrectomy and lymphadenectomy to put adjuvant tyrosine kinase inhibitors. So selection of adjuvant. It also gives indication of prognosis. Except those 3 exceptions which I told, higher stage is bad. It also helps us to evaluate the treatment. You have a LABC CA breast, you start neoadjuvant chemo, re-evaluate them. Tumor has now vanished, nodes have vanished, it becomes T0, N0. Now you add a small y and you can know y T is 1 or N0. So evaluate the response to the treatment. It also facilitates exchange of information between 2 cancer centers. Some of your friends sitting in France or US, they say, oh, what is your outcome in stage 3 post-cricoid malignancy? 0% 5-year survival. Everybody understand what you're speaking, common language. Then you can add the continuing investigation. So now you can look at it, okay, stage 3, CCA ovary will study IP chemo, HIPEC chemo. So investigational treatment can be done based on the staging. It provides a method to convey clinical experience to others without ambiguity. Like people would say, in our hands, stage 1, 2, 3 CO is very good. The moment it is stage 3, 4 B, I rarely see anybody being alive. Not many people know that in head and neck cancer, oral cancers and head and neck cancer, except in esophageal cancer, lung metastasis chance is less than 3 to 5%. That's why we don't do CT lung as a routine in head and neck cancer unless it is advanced. But CA post-cricoid has got 30% lung metastasis at presentation, so CT lung evaluation is required. So you can convey your experience to the others based on the stage. Then quality control of cancer diagnosis. We would say that if you start a hormone therapy in this patient, this is the outcome. So you can look at what is the quality. Suppose you have done an R0 resection, means quality. R1, microscopic positive. R2, I couldn't remove all the disease. We left a disease in the presacral area or on the prostate in an advanced rectal cancer. So quality of surgery, total TME done, circumferential resection margin, CRM negative. So these are the purpose of staging. No need to write down. What I will do is at the end of my talk, one of my students, Dr. Priya Kapoor, will post these particular slides in the WhatsApp group we have set up for students. So you can just listen today. I will hand over this presentation to Dr. Priya and she will post it for the benefit of everybody. Then you can keep revising, take a printout, keep in your library for your exams and for your junior, senior, for yourself. So now if you look that there are pathological staging and clinical. So small c, remember big P is different, big C is different. I'll tell you what is that. Small c means clinical, When you examine a patient, remember ultrasound, X-ray, CT, sometimes PET are an extension of clinical. If somebody says, okay, you do examine a patient of CA breast and you say it is stage 1. Now you have done an ultrasound of axilla node, you find. Now does it fit into CTNM or pathological? All of them as per the criteria is clinical extension also includes investigation, except pathology and surgery. So PTNM is when you have done a surgery. In several instances, histological grade, soft tissue sarcoma and thyroid are the two tumors where grade is a part of staging. Remember, this is always asked in a practical. Name two places where grade is a part of staging. GTNM staging, that is soft tissue sarcoma. There is a special name for sarcoma staging, read about it. And age in thyroid cancer are important. So there are more than TNM which are integrated, grade in soft tissue sarcoma, thyroid, age. There are some other places tumor markers and biological markers are and genetic markers are there. Biological marker is incorporated in the new HACC staging of breast cancer. If you do oncotype, low genomic biological profile in genomic, then even if they are stage 3 CA, they are treated and staged as stage 1. Testicular malignancy, germ cell, ovarian tumor markers are incorporated into the staging. Now, the main ICD, WHO put it into primary site, regional nodes, metastasis. I told you there are only stage 1, 2, 3, 4. Exception is Wilms has 5. Thyroid has stage 1, 2 in well differentiated early younger age. And then you have only stage 3 testicular malignancy. So, totally it forms 24 combination. If somebody asks, what is the stage grouping? Don't say T2, N1, N0. TNM is a TNM. Stage grouping is stage 1, 2A, 2B, 3A, 3B, 4A, 4B like that. Okay. All cases when you put final TNM pathological should be confirmed by microscopic. And I told you the exception, RCC, pancreatic tumor, hepatocellular carcinoma where alpha fetoprotein is 10-15 times high. These are the places you can go ahead and operate. Now we have 4 TNM, CTNM, P, pathological TNM, small r, retreatment designated, multimodality Y. Remember, big P is different, big R is R1, R2, R3, R0. Big C is C factor, I'll tell you what is that. So small c is different, big C is different, small p, big P, small r, big R, and Y is multimodality. In an LABC, started off with stage 3, you gave chemo, it became stage 1, then you write Y, T1, N0, M0, stage 1. So clinical examination could include CTNM, endoscopy, biopsy are a part of it. Pathological has to be sufficient surgery and sufficient number of nodes. Every disease in the body, HACC, designates minimum number of lymph node required. Remember, those of you who read NSABP 04, NSABP 04 trial is done by Halstead, which compared radical mastectomy, axillary clearance has the best survival. If you have done a complete axillary clearance, you have removed more than 15 nodes, the recurrence in the axilla is less than 5%. This is NSABP 04 trial. So, each trial in AJCC has 2 lymph node number, don't confuse. The minimum lymph nodes required to stage a disease when it is M0. Example, breast cancer clinically ultrasound M0. You don't have sentinel lymph node facility. Minimum node to be removed to say your staged axilla is 6. Don't confuse this with the minimum node required to achieve a good result when node is positive. Therapeutic lymph node clearance in a positive axilla in CA breast is 15 as per NSABP 04. But staging number is 6. I'll give another example. If you have a oral cancer, say buccal mucosa or tongue, staging surgery in the neck is SOHND. But a therapeutic surgery in node positive is MND or RND, comprehensive clearance. So for a staging axilla node number as per TNM is 6. Therapeutic, where is positive is 50. When you have SOHND, minimum node for staging is 6. When you do MND, minimum node removal is 12. In radical cholecystectomy, staging node as per AJCC is 3. When it is positive therapeutic, 7. So don't confuse between both. Staging is different, therapeutic different. So when somebody asks what is the ideal lymph node removed, then you must answer in breast would be, sir, in a clinically and ultrasound N0, staging purpose 6. If you have removed 6 are negative, you can say axilla is negative. You have removed 1 node is positive, then you cannot say therapeutically it is adequate, 15 nodes should be removed. NSABP 0 says when node is positive, 15 nodes if you have removed, axillary recurrence is less than 3%. If you have removed 10 nodes, axillary recurrence is 7%. If you have removed 6 nodes, the axillary recurrence is 20%. If you have not removed any axillary node, when it is positive, the axillary recurrence is 75%. So this is the NSABP 04. Read that. For every cancer, you have a data like that, and I can give you value for each cancer in the body like that, gastric, colon, like that. But please learn about this. Now we have certain values, which is Tx, T0, T1. So TIS means in situ. Ductal carcinoma in situ. Remember, according to new AJCC, lobular carcinoma in situ is not TIS. It has been removed from a malignancy. LCIS is not a pre-malignant condition now. It is not a in situ. It is not TIS. Now T0 means, suppose you have a big node in the neck, N3. You do a pan endoscopy, no primary identified. You do a PET scan, no identified, then that is called T0. Somewhere there is an occult primary, you can't identify it. TX means there was a lump, you don't know what it is. Outside, somebody in periphery, some doctor has removed the lump. Neither you sent for histopathologist to measure, nor you have an ultrasound before surgery to see 2.1 T2 or 1.2. So then the patient comes to you with a biopsy of one line, ductal carcinoma breast, size not mentioned, no. So then it is TX, primary cannot be assessed. There was an ulcer on the tongue, somebody removed it thinking it's benign, and then the report comes as squamous carcinoma. You cannot know what it is. In this time, you have to try to get the histopathology, speak to the pathologist, or open the ultrasound. Was there an ultrasound before that or a memo, or can you assess the size? So TX is somebody has put a knife and done, or somebody did some lymph node biopsy in the axilla for TB, and then it turns out and you don't know what is happening. So TX, T0, TIS, then we have 1, 2, 3, 4. Then remember, all the surface solid tumors, size is important. For oral cancer, T1, T2, T3. Surface epithelial lesion less than 2, 2 to 4 more than 2. Breast cancer, so 2, 2 to 5 more than 5. Like that, everywhere it is the size. But in GI mucosal disease, depth is used. It doesn't matter you have a 6 centimeter tumor in the stomach, it is not T1, T2, T3, it is the depth. So laminopropia, what is cut. So GI tract, urinary bladder, malignant melanoma, except squamous cell carcinoma skin, which we call epithelioma, and melanomas, in this depth is there. So remember where size is used, where depth is used. As I told you, you don't have to write down, I'll share the slides later. Same applies to P. You operated, you know, there is a scar on the breast and there is some induration. When you go and remove the lump, there is no tumor demonstrated. Complete lump has been removed by somebody. After pathological surgery by you, second surgery, still you cannot stage it. Then we say P, T0, TX, like that. Like for example, see, when a lady comes with this, I examine this. It is a C. Remember, always you have to use a calipers to identify. Otherwise, you will feel the normal best parenchyma and you overstage. So this is C. The same patient you excise, now I put a scale, now it is PT. Remember, this patient operated by somebody out, specimen discarded, no, or only one line, ductal carcinoma, no other, and they come with this scar, I don't know what was the T state, then this is TX. So look at this penile cancer, TA1 in situ, then you have T2, T3, involvement of urethra, then T4 at the shaft, base of the shaft of the penile cancer or pubic symphysis involved T4. So, you know, these are T. In urinary bladder, in situ, communicate only confined to basement membrane. First layer involved, inner one third of the muscle, half, more than one third, perivesical fat involved, T3, involvement of urethra, prostate, T4. So depth is involved here again like GI. Now another example, look at the gallbladder. If the tumor is on the free surface of the gallbladder facing the peritoneal cavity or towards the surface, lamina propria muscle breached, or if it is here, T1A, T1B. Suppose the tumor was on the liver, then based on the liver involvement T2. When you operate, you demonstrate the same pathologically T2. Why it is important? If somebody has undergone a laparoscopic cholecystectomy for a asymptomatic gallbladder for some benign reason, suddenly the report comes for adenocarcinoma, what to do? You get the pathological report, read detailedly, and if it is very well documented, it's T1, we know no further treatment required. If it is T2, T3, patient needs to go back to do radical cholecystectomy, hepatoduodenal staging lymphadenectomy, segment 4A, 4B, plurisegmentectomy, wedge of the liver should be removed. If it is T2, T3, if you don't do repeat surgery, then 5-year survival is 0% if you don't operate. If you do a repeat surgery because you state the disease well, looked for it, 5-year survival is 80% in T2. So you know the importance of staging now. Look at the other examples here. You have a low anorectal tumor. Size is not important. Depth is important. This is a case of CA breast. See how the muscle has breached the whole fat and gone to the underlying pectoralis major muscle, white area. So we know now pectoralis major muscle is in order to take a cuff. But chest wall involvement only is T4. Pectoralis major alone, no. Pectoralis minor, serratus anterior intercostal areas is important. See the other example. If you see the depth of endometrial cancer reaching more than 50% of myometrium, that's an indication for lymphadenectomy and radiation. So how important the staging is. There are some diseases in the human body which are surgically staged. Most of the solid tumors are surgically staged. In gynae-onco, ovarian cancer, endometrial cancer are surgically staged diseases. Vaginal cancer, CA vagina, cervix cancer are clinically staged diseases. CA vulva is again surgically staged. So you must know which are surgically staged, which are clinically staged. So if you do a systematic staging in CA ovary, then if you do a proper staging, 30% of the time it is upstage because there is a omental disease, washing is positive, peritoneal cavity is positive. Then that patient needs an adjuvant chemo. If you don't give chemo, 100% recurrence and loss of survival. So the importance of proper surgical staging, which is very, 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 very important. Now, what are the chances of occult metastasis based on T? In general, if you have a solid tumor surface, let's take an example of breast, tumor is less than 1 centimeter, chance of occult metastasis is 25%. So you do staging surgery, SLNB or staging. The moment you cross 2 centimeter, look at this. The T status and lymph node status correlate. Same example I'll give you. If a base tongue lesion in oral cavity is there, occult metastasis is straight away 25% for T1. Same T1 in buccal mucosa or lip, occult metastasis is less than 5%. So SOHND is permitted, but not for base tongue. SOHND is not permitted. So that's important. So for each tumor in a site, there is a fixed number of node defined. I have already told you. In rectum, if paraaortic node at the beyond the origin of IMA is there, it is M1. That's why when we do a ligation of IMA, the node at the origin of IMA we keep separately because they are positive, they are M1. In stomach, the first thing you do for curative D2 radical gastrectomy is do an extensive cauterization, lift the stomach, you are going to see vena cava and aortic area on the retroduodenal area, which is also called as trach fascia. The first node you encounter is 16A, 16B. They removed first cenfofrozen positive, their M1 curative D2 radical gastrectomy is ruled out, no survival benefit. So these are very important. In esophagus, I told you, celiac node supraclavicular is non-regional node M1. So there are some places where non-regional nodes are also staged as M1. Distant metastasis, you cannot assess distant metastasis in some place. You don't have the facility to do that. Then you can say MX. In exam T and MX because you are not yet known what happened. And then distant metastasis. Again in M1 in the bracket you can write M1 pul means pulmonary, M1 OSS osseous, because we know in CA breast stage 4 because of isolated bone mats they behave like stage 3, they routinely live 5 to 10 years. So there are some M1 status where they live. For example, colorectal cancer with liver or lung limited disease, they still have survival benefit up to 10 years, they can be cured. So when you write M1, if you write is it with the bracket PUL, OSS, brain, lymph, it gives a good. So when you write TNM, remember you write M1 but you write in the bracket only OSS. So people know very well only isolated, or you write M1 a non-regional lymph node. So you can write that. So this is all evidence based. For example, see this parotid tumor with skin involvement. Straight away you know it is T4. For T4 lesion with high grade parotid tumor, elective neck dissection should be done. Put orange you have. So T4 in the breast. Straight away LABC. Ulceration, satellite nodules. So you can see the pid orange you have. So all these are T4. Look at this minor salivary gland tumor in the hard palate here. Eroding the hard palate going into the nasal cavity. Straight away we know it is T4. Minor salivary gland tumor, high grade salivary gland tumor, elective neck dissection required. See this, CA stomach, posteriorly it is breech fixed to pancreas. So straight away you know T4. Curative intent impossible to operate them. You see the CA right colon, cecum and ascending colon. It has invaded, gone to the ureter kidney. Straight away you know it is T4. So some place where the imaging straight away gives you away. This is the case of CA esophagus. There are two dictum in oncology. If a case of CA stomach comes with palpable mass per abdomen, they are rarely operable, they are rarely curative. If a case of gallbladder cancer comes with jaundice at presentation, not periampullary, not pancreatic, gallbladder, they are inoperable, they cannot be cured by surgery. If a case of CA esophagus comes at presentation with this tracheoesophageal fistula, they are non-curative and palliative. If you do a barium water swallow either with CT or simple X-ray and there is an axis deviation in esophagus. See, axis deviation means the barium comes here, then it makes a H and comes. Axis deviation in CA esophagus, they are not operable. Always they are involving the bronchus and aorta. So these are some of the dictums. If you have done an endoscopic ultrasound, look at it here, big node. So the moment it is node positive in esophagus, the minimum stage is stage 3. That is not a candidate for upfront surgery as per the cross protocol, neo-adjuvant chemoradiation. So that's why it is important. Pathological stage is at the end of the surgery. Again you classify it as NX, N0, M0. That is what you identified. Now this is what I told you. Don't confuse minimum nodes required for staging to therapeutic. Minimum node required in breast is SLNB or 6. As per the AJCC, 10 radical neck dissection, 12 Wardheim's radical hysterectomy, 15 colorectum, 15 Whipple's, 15 radical prostatectomy 3. So read about it, make a notes and keep it. You know, when I was a student, I had entire book in the tips, every line, every page, every para, in and out controversies I have. You ask me a disease today, for that particular number of notes required, I'll give you. You give me a stage and a number of disease, then that particular stage I'll tell you what is the incidence of lymph node. If you have a T1 supraglottis cancer, bilateral involvement, 11% is the chance. If you have a T2 squamous cell carcinoma oral, the chance of level 5 node involvement is 3%. I can give you any percent for any T for any combination. So try to master that. You know, you just have taken a career of surgical onco, you have to master it. So similarly, remember all the station of nodes for esophagus, for lung cancer, for stomach, you must master them. And the most important is around the recurrent laryngeal now. So please read about them. This is always asked. Right RL, recurrent now, RL, what station is that node in esophagus? Left recurrent node, what station it is? This is always asked in exam in practical. Please learn this. So for esophagus, minimum 15 nodes for staging. Remember, this is for staging. The moment node is positive, what is the minimum number of nodes that is required in esophagus of stomach? 30 as per the Japanese classification. If you have done a 2-field lymphadenectomy, you have done a D2, 30 is the minimum node therapeutic, but staging 15. So don't confuse with that. So as I told you here, if you have a colorectal and it is beyond IMA, it is non-regional node stage 4. So minimum 15. So go back and read about it. So this is what I told you. Staging, if there is, this is NSABP 04. If no axillary dissection is done, what is the chance after multimodality treatment like chemo radiation, still axillary recurrence 20%. NSABP 04 trial showed if you remove less than 5 nodes, recurrence is 12. If you remove more than 10, recurrence is 0.3. See, NSABP 0 trial. Like that, for every trial, there is a fixed number where you know what is it. Please learn this. If most of your exam would ask this in theory or practical. So, radical neck dissection. I have enumerated all of them. Stage 1. Now, you know that stage 3 highest node involved lateral to the pectoral are now counted as infraclavicular node, and if that node is positive according to new AJCC, that may be the only one node positive, still it is stage 3. So it's very important to understand. So the exceptions are if you are doing sentinel lymph node. So that is when you do. Now what do you mean by T0N1? A lady comes with a axillary node, you do ultrasound guided core biopsy, they say adenocarcinoma ductal CA. You examine the breast, nothing found. Mammogram done, nothing found. Ultrasound breast done, nothing found. Then the investigation of choice is what? MRI. It is stated that MRI with breast coil, if you do MRI breast in an axillary node, 70% it can show the occult primary in the breast, usually in the upper outer quadrant or axillary type. In spite of MRI, clinical examination, memo ultrasound, you can't identify, but the core biopsy is ductal cell carcinoma receptor positive, then you stage it as T0N1 and the PET CT is negative. The most important modality of investigation for MUO, metastasis of unknown origin, is PET CT scan. Highly sensitive if it is head and neck cancer, lung cancer, esophageal or GI cancer. Remember this. The investigation of choice for MUO axillary adenocarcinoma is what? MRI breast with breast coil. So remember this, it's all written in Devika. Now I told you there are importance that you have to write grade. Just don't write TNM. You write grade 1, grade 2, grade 3, grade 4 because they indicate, we can't interact to you. I'll tell you one most important reason why grade is important. If you are treating STS, soft tissue sarcoma, LC or staging system, if it is grade 1, grade 2, that is a well differentiated or low grade tumors, in them interstitial breaking needle is not useful. This is very important. In exam we ask soft tissue sarcoma you have, when would you use external beam radiation? When would you use interstitial needle brachytherapy? Interstitial brachy is put during surgery or immediately after surgery, single time, one day and then removed. You cannot kill a cancer if it is low grade because the cell cycle, chemo and radiation acts best between G to M phase, which means one cancer cell in that area should complete one cell cycle to die by radiation or chemo. Lower grade tumors multiply by days, 1 week, 2 days, 7 days, 1 month. So you cannot kill them in their one complete cell cycle if they are low grade. So low grade tumors, external beam radiation given daily over months. So you will catch that one cell at different phases of cell cycle. If it is grade 3, grade 4, high grade, they multiply in hours and so interstitial brachy can catch them in one phase. So soft tissue sarcoma, higher grade tumor, interstitial needle brachy. Low grade, external beam radiation. So this is the answer you must tell in exam. So also if there is a lymphatic emboli, we ought to write L1, N0 because this suggests lymph node involvement chances are high. Occult lymph node, they can spread out, chemo important. Higher grade brachy versus EBRT. Next thing is perineural involvement. If there is a perineural involvement, like you have in adenoid cystic carcinoma, minor salivary gland, or you have in pancreatic cancer, posterior stomach cancers, or breast cancer, radiation is required. Now see example, well differentiated tumor in colorectum, distal margin is how much? 2 cm. The moment you have poorly differentiated tumor, you need 5 cm. There are 2 margins. Mucosal margin of resection is different, mesorectal margin is different. If somebody asks you, in a sphincter preservation rectal cancer, what is the distal margin? Your answer is, it is based on the grade, sir. Well differentiated to moderate differentiated, distal mucosal margin is 2 cm. Poorly differentiated distal mucosal margin is 5 cm. However, mesorectal spread is 2 cm beyond the mucosa, so the mesorectal margin is 4 to 5 cm. Mucosal is 2. That's why there is a frill of mesorectum beyond the mucosa. So this is a very important tumor. Soft tissue sarcoma, higher grade brachy, low grade external beam radiation. So now you know how grade of TNM identifies the whole treatment. Now we know what is small r. I told you already, small r, small y. Now capital R. No residual tumor at the end of surgery, R1 microscopic disease positive, R2 macroscopic. Like for example, circumferential resection margin in rectum, pancreas, head and neck. That's why, what is the treatment in head and neck cancer? Tri-dimensional 1 centimeter margin excision, mucosa, soft tissue and CRM. That is an answer. So wide excision means tri-dimensional 1 centimeter margin beyond everywhere, including soft tissue and CRM. So R2 means macroscopic disease. You couldn't remove beyond IVCR vessel, so that is it. Okay. So R0 resection. CA base tongue 1 centimeter, no dissection done, R0. This is R1. Poorly differentiated low rectum. It appears normal, but see, submucous spread is there. This decides the margin status. Second important, see, remember, it's very important to understand what is the margin state in oncology. Squamous cell carcinoma oral cavity 1 centimeter tri-dimension. CA larynx 2 millimeter. This is accepted. You can write it down, but I'll give this presentation. Dr. Priya will share with all of you. Hypopharynx more than 2 centimeter. There are few places in oncology margin is 2 centimeter and above. Number 1, hypopharyngeal cancer. Second, phylloid tumor of the breast. For ductal carcinoma, margin is no ink, millimeter, but phylloids 2 centimeter. Next, dermatofibrosarcoma protuberance of skin, 2 centimeter. So remember, there are some places where it is more than 2 centimeter in other one. CA stomach, proximal margin 5 centimeter, distal 2. Why? Proximally it goes through submucosal spread, so longer. Distally, because of the lymphatic pattern towards the pylorus and duodenum, it is concentric. So it is not submucous. So they perforate and penetrate distally. That's why 2 centimeter. This is an answer. Remember, lymphatic pattern, circumferential, so they penetrate and perforate, not submucous. So 2 centimeter distally in the stomach. Esophagus, adenocarcinoma, 5 and 2. Squamous carcinoma, proximal distal 5. That's why you end up doing almost full esophagectomy with small remnant in the neck to do anastomosis. So you can't do a segmental Ivor-Lewis for squamous cell carcinoma, unlike G junction adenocarcinoma. Colon, proximal 5, distal 5. Rectum, proximal 5, distal 2 for well differentiated, distal 5 for poorly differentiated tumor. Skin, squamous cell carcinoma, epithelioma 1 centimeter, basal cell carcinoma 2 millimeter, melanoma based on Clark-Breslow, it could range from 2 millimeter up to 2 centimeter. So liver, hepatocellular carcinoma 1 centimeter, metastectomy 2 millimeter, lung 1 centimeter, bronchus 2 millimeter. So every cancer, please know what is the recommended proximal distal margin. Every tumor, you ask me, it should be in your tip what is the margin. Okay, I can just tell you at this moment so you can understand. Second, see this tumor in the stomach, multiple tumors. So if there are multiple, this is the breast. See, can you see 2 tumors? If you have multiple, you write T2 bracket M and how many M? M2, M3, M4. People will understand. T3 stomach bracket M3 means multiple 3 tumor. CA breast. T3 bracket M2 means 2 multiple tumors. So how do you classify if there are more than 2 tumor? Classify both of them like this. See T2M, T25, 5 tumor. The staging of the highest tumor takes the precedence. Always. People will ask, so papillary CA thyroid, sir, one small 1 millimeter of anaplastic component. Immediately staging says us to the worst outcome tumor to that stage. So always it is like that. We also have venous involvement, which is reported as V1, V2. Microscopically, the pathologist says V1. Macroscopically you can see, where, see this, renal cell carcinoma, vena cava and renal vein involved, V2. Grossly it is normal, but the pathologist says venous involvement is there. So this is a marker for systemic lung metastasis. So you can discuss. So there is a tumor thrombus in vena cava. As per the new evidence, adjuvant, even though you have done R0 resection, these patients are put on adjuvant sunitinib. Then perineural, PN plus, PN negative, adenoid cystic carcinoma of salivary gland, PN plus. That's why when we cut the nerve at the foramen ovale and see if node is positive, if the nerve is positive, intracranial, recurrence, infratemporal fossa recurrence is high, so RT is given. Then rectum, tongue cancer, if there is a perineural invasion, very important marker for local recurrence, radiotherapy may be considered brachy or EBRT. Same way, it is very, very important. Lymphovenous invasion in endometrial cancer, as per the new staging, POL, MSI, we use, they are an indication for adjuvant treatment, even though it may be stage 1A. So now you know how important every component of TNM staging is. Once you arrive at all these, then you have a stage grouping. So T1, N0, 1A, 1B, 2. Remember, stomach cancer staging and new HSCC breast cancer is roughly same. T3N1 stage 3A in both. T2N1 stage 2 in both. So you must understand roughly the similarities and then learn it. That's how I put it. So why it is important? If you have stage 1 stomach, 70% survival, 240. So stage decides the whole outcome. Remember, everywhere in general, stage 1 is excess of 90%. Stomach, and then squamous cell carcinoma, oral cavity, tongue, it is never even in stage 1 above 90%. So there are some exceptions. Pancreatic, gastric, and tongue cancer, stage 1 outcome usually starts from 75 to 80%, not from 90. Remember this. So don't blindly say, oh, everything stage 1 is 90% and bluff it. Okay, it's very, very important to understand this. Tumor markers are very, very important in testicular malignancies. We have S1, S2, S3. Even if there is a lung metastasis in testicular malignancy, it is only stage 3. So you can go back and read staging for testicular malignancy, germ cell tumor. Type of lesion also needs to be analyzed, endophytic, exophytic, ulcer-infiltrative, because exophytic are well differentiated, better outcome. Ulcer-infiltrative is poor. Endophytic, in case of larynx, could have paraglottic space, pre-epiglottic space involvement, which makes it T3 minimum stage is stage 3. In head and neck cancer, T3 directly goes to stage 3, even though node is negative. See this exophytic tumor, well differentiated, margin 2. Ulcer-infiltrative tumor in the colon going into the kidney erodes both their T4s. So that's why this is very important. See this specimen now. T4, colon invading the kidney, ulcer-infiltrative, larynx, paraglottic space boundary, pre-epiglottic space boundary, please learn, because it is T3, then you usually lose a chance of voice preserving surgery in them. So ulcer-infiltrative tend to be advanced T4 very fast. Age is a criteria in thyroid, as I told you, less than 45. Even if there is a lung bone mass, only stage 2, but above 45 years it is different. For sarcoma, you have GTNM staging, which I told you. Next is capital C factor. What is capital C? Small c you already know. C factor means once you put TNM, what is its validity? This is asked in practical. I ask, whenever I am an examiner anywhere in India and DNB surgical, I ask, after you operate, you get a histopathology, you have a TNM. What C factor is it? This is called as certainty factor. C1 means if a TNM is arrived with diagnostic modality and investigation, that is capital C. Don't confuse small c. C2 means you have done some biopsy, some investigation. C3 means by surgery. So, routinely P, pathological TNM, which you put after the surgery seeing histopathology is C3. Remember this. There are some we don't know. Patient dies, we do autopsy C5, like CA ovary. Autopsy staging is most accurate than any other staging. So remember, what is the normal C factor in TNM? It is C3. Surgery, autopsy is C5. We know C3, C5. So this is an example. See T3, C2, N2, C1, C2. This is how you can put. So what I will do is, there are certain changes that have happened in new TNM. I will summarize in next 5 minutes. In DNB surgical oncology OSCE system which we made, at least 10 questions are there based on What is thus change between old HSCC and this HSCC? If you are in practical, always this question are asked. Every year in DNB, one question is there: what is changed between old to new, HSCC? So I have put here. There are totally 7 core committee, 420 contributors, 181 institution, 22 countries, 16 continent, which made this particular staging. HPV is also incorporated in this. And then remember, bone and soft tissue we have a separate staging. Separate staging for patient with neoadjuvant therapy in esophagus and stomach. So there are new features which are added, which is for thymus, for bone and appendicular, for HPV related oropharyngeal cancer in page 15, cervical node in head and neck cancer, and risk stating, and also cervical cancer, CA cervix is all changed. So these are the things which have been changed, which is there in the new. So what I will do is, what is changed? Lobular carcinoma now in the new staging is not a cancer. Now breast cancer is staged based on genomics. If you have done Oncotype DX, it is low, it is stage 1. So these are all the stages. Multi-gene panel is involved in CA breast in new staging. So it's a new HSCC which has changed here. And lobular carcinoma is changed. Nodal system has changed if there is an intramammary and axilla. Go back and please read about this particular thing, which I am not going to cover now because of the time. Now there are some revisions that have happened into low and high risk in another part. So I will tell you what are the other things which has got changed when you see the new other things. In gallbladder, this is what has changed. T2A, T2B has been changed based on peritoneal or hepatic side. So this is based on level 2 and level 3 evidence which is there. So T2A, T2B in gallbladder change. Draw this figure in exam. When you write in theory, please don't write theory. Always put one chart, one table, and one drop box. And this is what is changed. There are over 10 Hosky questions in DNB surgical onco based on only what has changed, because they found that this is outcome is also different on either side. That's one of the reasons. So you can see this gallbladder in 8th edition. This is what has changed. And what is changed in carcinoma cervix? N1 is removed from stage 3B, and paravetic has been subdivided into based on the different evidence. And MRI and PET has been added in a CA cervix staging. So this is what has changed in CA cervix. So you can go back and identify. 8th edition of uterine cancer also has changed. Now we have clubbed this B1, it's divided to B1, B2 and A1, A2 is also clubbed and changed. Paraetic node is classified into 3A, 3B. You can go back and read these are the changes. Reproduce this in your Hosky and exam. In oral cancer, extrinsic tongue muscle invasion is no longer used for T4. It was there before. And again we have added ENE, extranodal extension has been added in that. And the depth also has been changed. 2 cm but 5 mm to 10, less than 10 and more than 10. This is Spiro and Spiro's work from MSKCC. So these are the changes which are there. So you go back and read. So in conclusion, you must know all the changes. I have just stimulated. See, the purpose of a teacher is not to spoon feed. I can't spoon feed you like a baby. It's just to show a direction, stimulate your brain. You have to go and look at the direction from the teacher what he has shown, and stimulation we give, go and read. Now every cancer should have this in your residency. You should carry these forms. At the end of every patient you put this TNM stitching, tick TNM, CP, unilateral, bilateral, left side, right side, patient name, hospital number, who has staged it. Then when the surgery is over, go back and update and put the date on that day. Then stage grouping, then see G, grade, R1, R2, R3 is a section, lymphovascular space invasion, then everything. Then you write what are the other prognostic, ER positive, PR positive, mark the tumor, sign, seen by this resident on this day, this well. Every tumor. So how do you completely stage? Infiltrative ductal carcinoma in a premenopausal lady, P after surgery, T2, N0 grade 3, it is not multiple tumor, otherwise M2, V1, G3, L1, PN, perineural in M0, stage 2A, C factor C4, R0 resection, prognostic marker. So this is how a complete staging is done and ticked and done. So in conclusion, how a child takes the first step to walk for milestone, that's how staging is. This is the main foundation. First step for us to decide the treatment, curative, palliation, prognosis, adjuvant treatment. Oncologist needs to constantly update your knowledge. Every time a new TNM comes, we look at it and then we do it. Thank you very much. I will now just look at it because we need to end this in another 5 minutes. I'm just going to open the chart and see if there are questions. I'm going to answer this particular area, whatever we have. Number one, LCIS, I told you, even see, there are two things in oncology you must understand. Precancerous and pre-malignant, both are totally different. Leukoplakia is both precancerous, pre-malignant, pus reversion syndrome is pre-malignant. So, LCIS now no longer is a cancer, it is not in situ, it is not TIS. It is listed as a factor for high cancer, it is moved out of TNM. Can you, next question is, okay, can you enumerate cancer in which staging laparoscopy is recommended? Yes. Pancreatic, body pancreatic cancer, tail pancreatic cancer, distal body, laparoscopy staging is recommended. Liniatus plastica, signet cell carcinoma, stomach, staging laparoscopy is recommended. CA ovary, advanced, recurrent, you want to do staging laparoscopy. Why? There is an MD Anderson trial which showed in distal body pancreas and tail pancreas, if you do staging laparoscopy, 20% occult peritoneal mats are there which you can assess. Normal well differentiated CA pylorus staging laparoscopy yield in a modern era of good CT scan is less than 3%, but signet cell liniatus plastica, the uptake is 17 to 20%. This is a question you should actually, answer. You are a student. If you read Davita, it is written. So these are the four things where staging laparoscopy is mandated for you to do. CA ovary advanced for recurrent surgery, or if you think that you don't know whether you can resect or to do PCA assessment, liniatus plastica put in stomach, and distal body, not for periampullary and proximal body. How the depth of invasion is assessed in oral cavity. MRI is the best assessment, or ultrasound high frequency probe. Final is histopathology. So these are the three ways you can assess the depthing. See, remember, oral cavity means tongue, floor, mouth. But for paranasal sinuses, RMT and infratemporal fossa, it is MRI. Then the next question is, in CA rectum well differentiated in advanced RAL, distal margin resection is, remember now the margin changes when you give neoadjuvant treatment. Well differentiated adenocarcinoma, if it is 2 cm before multimodality, as per the MSKCC trial, if you are giving neoadjuvant chemotherapy to downsize, then do a sphincter preservation, 2 mm is accepted. When you do coloanal intersphincter resection, ISR resection, well differentiated, post chemotherapy 2 mm is accepted. So these are advanced things you must actually understand. Then how is the depth of invasion? I already told you. Explain the staging of CA esophagus and squamous based on location. What we will do is, next symposium students will run, and then I will give you, make them do this particular area. Okay, then thank you. So this completes my staging. This is a very, very important thing, which is excellent topic, which least concentrated by most of the students. Most of them don't answer in OSCE, DNB, theory and practical because they don't read this. So we end this session today. We have 251 people, and please use this for well. I will share the presentation with Dr. Priya Kapoor. She is going to help all of you for your benefit. We'll put it in PDF file. Don't misuse it. Please use it for better use. Thank you very much, and I really thank DNB board Ji for you very much. With patiently you are sitting and listening. We are students and doctors. We can listen, but it's a lot of patience for you to listen. Thank you very much. Over to you, sir.
Thank you. Thank you very much, Professor Dr. Somashekhar, for the presentation. And thank you very much, students, for joining us.
Thank you very much.